This session is a quality assessment in cabbage. The first speaker is Dr. Teresa Kisa, TTFM. What do the number mean, please?
Okay. Good afternoon, dear colleagues, ladies and gentlemen. We're going to talk about today, what do those numbers mean? I have been doing intraoperative graft assessment, TTFM, for 19 plus years, epicardial ultrasound for 9 years, and these are my disclosures. We all know the numbers, flow, pulsatility index, diastolic filling, but you know the waveform is extremely important, so we're going to be including that. That little probe you hold in your hands is very, very special. It has these little 2 tiny transducers that measure that flow. Pulsatility index is a measure of the resistance, and I just want to make one thing clear. The calculation takes 5 cardiac cycles, and it takes that long to see that horizontal line come through. Acceptable is 0.3 or less than 3 and less than 5. Diastolic filling does not have too many papers written about it. I don't think there's any, but we need to know first the left vessels fill in 60-70%, the right vessels fill in 50% of diastole. That's because of the lower pressure in the thinner right walled ventricle. If there is a difficulty in trying to figure out whether the flow is or the PI is good or bad, it's the fault of flow. And this is because flow is dependent on so many things: size, length, quality of the conduit, native artery, runoff of quality of coronary bed, mean arterial pressure, heart rate, competitive flow, viscosity of blood, quality of proximal distal anastomosis. So the permutation and combination of all these things is impossible to figure out. I just want to make one sort of note about the paper that we did a few years, 13 years ago. I did revise 2% of the graphs, and after having used this machine for about 3 years, I had no gestalt as to whether this made a difference or not to my practice. So I thought I would review it, and to my horror, I realized that if I had ignored the machine and thought I was right, I had harmed my patients. Flow and diastolic filling were not predictive of outcome, and this was even more apparent in the bar diagram. MACE, all mortality, and even when we excluded emergency patients. So believe the machine more than you believe yourself. So let's look at some cases to describe what do these numbers mean. Okay, flow's 34, that's okay. PI, well, that's a little bit high. So, oh my goodness, after protamine, PI goes to 59.4. Revise the graft, and this is after the second go after protamine. It looks a lot better. And yes, this is a case of graft revision. In situ reto to PL became a free reto to the aorta. Okay, what does this look like? Anybody? It's the pink spike sign, okay? And immediately after revision and post-protamine, you see a difference. This is a really important point. If you see this typical progression of the waveform from an occluded graft when revised, you have had not a good graft. It's because what happens is the flow is exaggerated, the PI is very low, and due to vasodilatation of ischemia, this is what causes this excess in flow, and the flow settles down. So yes, this is an occluded graft. Oh my goodness, not another occluded graft, the pink spike sign. This is the probe near the origin of the right mammary artery, the subclavian artery. Probe midway in the reta, and probe near the distal anastomosis. And final TTFM. So this is not an occluded graft. This is a case of a different probe placement on the reta to PDA, proximal, mid, and distal. This artery was born a systemic artery. That's what it was born to be. So it takes a little while for it to become from a systemic artery to a coronary artery. Now this is an odd one. You see a lot of systolic flow and some diastolic flow, and so what this is a lima in situ, an arema in situ. This is post-harvest, it's still attached, and it's still a systemic artery, so you do see the pink spikes. Now, if you're worried about a mammary, I had a case like this less than 4 weeks ago. I looked at this darn thing. It was an 84-year-old fellow. Every time I touched it, it was bruised. I imaged it, and I just discarded it. I didn't waste any time. I went for a vein. Okay, this is 12. 2.9 is okay, but the waveform doesn't look right. With proximal snare, looks even worse, so revise this one. This was an example of a bad graft unmasked with a proximal snare. So here we've got, this is reasonable, the flow's a bit slow. With proximal snare, 34.8, that's better. So what have we got here? When XXX is present and tested with the proximal snare, the flow through the conduit usually increases and the PI decreases. And in this case, the LAD was only 70% stenosis. So what is this? This is an example of competitive flow. Here's another one. Now we're seeing here for the first time backward flow. This is backward flow or insufficiency. And with proximal snare, it looks good. Boy, it's still not looking good without the snare, and you're really worried about this. So, but I knew the history, and this was a case of extreme competitive flow, and there was clot. This is our heart picture that we have for all our patients. There was clot in the left main. They showed, but they could not tell if there was any stenosis. So when I went out to talk to his wife, I said, well, my dear, he has 2 very good grafts if he ever needs them. So how accurate is transit time flow? A true positive TTFM is rarely wrong. False positive, it rarely occurs and is usually due to improper probe position. This is where the TTFM caught the probe changing. You can see it really can alter. True negative, TTFM's ability to predict this is 98.4%, and this is the work of Steve Freems. False negative, this is the Achilles heel. Poor graft, low PI, due to only retrograde use, retrograde flow. So this is the what's happening. The toe is obstructed, the flow is going backwards. So here's in a case, okay, the pink spike sign again, took the extra stitch out for the leak, put the stitch in again, okay. So we grafted the diagonal instead of the bigger, the LAD. And the LAD was diffusely small and diffusely diseased and small, and the patient never looked back. The diagonal was big, so you don't have to worry about changing your plan. So this is Lima to LAD with proximal snare. This is a Lima to LAD with distal snare. And this is with no snare. I'd like to know how many in the audience knew that there was a button on the Medistim that said distal snare, and if you've ever used it. And this is when you use it, it's used to verify the heel of the LAD anastomosis, i.e. retrograde flow. And we won't go into this topic because it's quite involved, but if you have an isolated left main and you want to do one bypass and you check the proximal and distal, you can. And with ultrasound, of course, too. So here's a case. Now, if you look at this, in retrospect, you can see there may be a problem. The PI, this is on cross clamp 0.3, 16 cc's a minute. And let me just run over my mouse. Here we go. And this is what you see on ultrasound. What you see the distal, the Lima, the retrograde flow, and these 2 little spikes are leaks. So there is no forward flow. And this is, of course, it would happen to be a lawyer. And this is, again, what's happening. And you can see all these septal perforators can actually cause an awful lot of flow. And here is the revised version. And if you look at this revised version, look at this septal perforator that he was missing. They wouldn't have gotten. And the flow is much better. And this is a comparison. So in retrospect, if you look at 46.2, the LAD is a huge vessel. It's 2/3 of the blood supply of the left heart. So I should have had a bell go off in my head when I saw 16, because that's not enough for a Lima to LAD. And this patient is 8 years post-op, running 10 Ks a daily and doing his Peloton 3 times a week. So this is an interesting case. Lima to LAD, this is on cross clamp. I always like to do it on cross clamp because then I know for sure. And when we're coming off pump, we're getting a little bit of backward flow, and the Lima has a lot of backward flow. So you can press a button and look at insufficiency, which is backward flow, 7% for the Lima, and 61.1% the Lima. It still didn't clue me in. So this is the history I did not give you. 62-year-old man, history of smoking, intermittent dizzy spells for the previous 4 years. Post-operatively, the dizzy spells increased to all every day. And at 4 days, he was not able to sit up or walk easily without physio assistance, and the bell light went on my head. We did a CAT scan, and it showed right subclavian stenosis. And there's the stent. So he, after the stent placement, the patient immediately felt better, completely better, while on the angio table, got up and walked home. I'm just kidding. So several studies have shown indicate limitations of TTFM. Norgard, which is the work of Rune Haverstad, showed that a 75 mean luminal stenosis was only marginally decreased the flow. Jokinen warned of potential unnecessary graft revision, found these patent grafts with these values, and they concluded better methods are needed. This was a review within a review that I did showing that 53% of the anastomosis were a problem, and 23 and 1 subclavian stenosis. No problem was found only in 6. Niklaus did a literature review of 9 studies and found that PI greater than 5 had a predictive value, and vein grafts needed more than arterial grafts. They concluded that TTFM was not sufficient and that there was no visualization of the anastomosis, like presaging acardial ultrasound. Guidelines, at first we were thrilled in 2010, class 1, level C, everybody's happy. Then, oh my goodness, we had a downfall, or not a downgrade, if you will, class 2, level C, and then it went up a little bit in 2018. Why did this happen? Because transit time flow with the first guidelines was a new kid on the block, and everybody thought it was like better than sliced bread. Then, as people started to use it, they realized that they're scratching their heads some of the time. So these changes reflect the increase in worldwide, but studies questioning the absoluteness of TTFM. DiGianmarco did a phenomenal study here, and I think this is one of the most important studies. He used both TTFM and ECUS and found a positive predictive value of almost 100% and 99%, whereas with TTFM alone, 10 and 98%. 39 grafts were found to be imperfect with TTFM, and ECUS only confirmed 2 to be failed. Therefore, ECUS prevented 37 of 39 revisions, and 2 with poor TTFM confirmed with ECUS. So ECUS has the final say. So the basics of TTFM are learned in about 5 to 10 patients. The nuances of TTFM take 5 to 10 years. Most TTFM values are obvious, good or bad graft, but in 10 to 20% you're left wondering, should the graft be revised? Maneuvers such as proximal snare and raising BP can be useful. TTFM measures function, not anatomy. Would we do everyday bypass surgery without an angio? Even CTAs are not yet accepted. Then why do we not use intraoperative color angios, aka ECUS, to verify? Epicardial ultrasound gives the final anatomical assessment. Off-the-wall question for the audience. Users of intraoperative graft assessment, would you perform elective bypass surgery without either TTFM or ECUS, or without both? Food for thought. Thank you.
Questions or not?
Do you want to?
Any questions or a comment?
We might save them for the end so we can stay on time if we have time. I think, there's no.
Yeah.
You can come and talk to us afterwards.
Thank you very much.
Okay, good. Okay. Hello. Okay. So, Dr. Taggart, Professor Taggart is going to discuss 3 cases that changed his life and a patient's life.
Thank you very much for the opportunity to make this presentation. I'm going to show some practical examples of the potential benefit of TTFM and high-frequency ultrasound, and then I'm going to show you some case scenarios. But my Japanese colleagues are not allowed to answer because I showed them this last week in Japan. So everyone can answer except my Japanese colleagues. So let me first ask, how many people in this room routinely use TTFM for measuring grafts? So 2/3?
Yeah, Japanese.
And how many use high-frequency ultrasound in addition to TTFM? So considerably less. Okay, so a minority. So let's just go through this quickly. So my major conflict of interest here is that I have been an advisor to Medistim. I've received research funding, speaking and traveling fees. But I want to make a couple of points just before we go to some cases. And the first is that most failures of grafts in the operating room are undetected at the time. They're usually asymptomatic. There's no change in hemodynamics, echo, or ECG. But when you're sitting at home at night and it's 11 o'clock and you get a phone call, you think, who's calling me at 11 o'clock? So you answer your phone and they say, it's the hospital. And they're not phoning you to say, Prof, you did a great job today. They're phoning you to say, we've got a problem. And the important point of this is that often the failure of grafts in the operating room at the time do not declare until several hours later. Teresa's mentioned there have been various recommendations for the use of quality assessment, but it's very interesting if you look at the use throughout different countries. So in Japan, over 90% of patients get quality assessment. Germany and Scandinavia are somewhere about 70, 80%. The USA is about 25%, and the UK is around 5%. And the next question you have to ask yourself is, can you just use TTFM alone, or should you also be using high-frequency ultrasound? Now, very briefly, this was a study, the request study, which we published in the JTCVS 2 years ago. Over 1,000 patients in 7 high-volume centers for CABG surgery, 4 in Europe, 3 in North America, and using both the TTFM probe and high-frequency ultrasound. And these were the key findings that we found. So these were by pretty experienced surgeons. And we found that for off-pump surgery, assessment of the ascending aorta led to changes in almost 40% of the strategic maneuvers to manipulate the aorta. For the ascending aorta, 14.7 off-pump versus 4.3% on-pump, conduits 0.2 and 2.8% respectively, and for coronary targets, 4.1% and 3.5%. In terms of graft revisions, and bearing in mind these were quite experienced surgeons, these were not novices, 4.7% of all arterial grafts were revised and 2.5% of vein grafts. And quite surprisingly, what we found was that in terms of territory revisions, the highest rate was to the inferior wall at 5%, the anterior wall at 2.9%, and the lateral wall at 2.8%. And that's quite surprising, because most people think that the highest chance of need for revision is the lateral rather than the inferior wall. And we published this paper, as I say, in JTCVS in 2020. And then I was asked to do an editorial for JTCVS about post-cardiac surgery myocardial ischemia. And what was interesting in this paper was the incidence for isolated CABG in large series where there was documented perioperative myocardial ischemia, and we only looked at papers with at least 500 patients. And we found that the overall revision rate was 3.9%, but it varied per series from 2 to 5%. And we stated that 2/3 of these cases had the origin of the complication in the operating room. We specifically wrote, graft-related complications represent the most common cause of perioperative myocardial ischemia, accounting for approximately 2/3 of cases. This broad group includes technical errors leading to direct graft injury and subsequent thrombosis, graft kinking, and an anastomotic problems such as stenosis, competitive flow, poor distal runoff, and graft spasm. So the point of this is the incidence of perioperative myocardial ischemia, everyone says, I've never seen it. But if you look objectively at what the evidence in the literature shows, it's more common than you would think, and it's what causes that phone call at 11 o'clock at night. So what happens when it all goes wrong? And what I've said is that the important thing to take away, if you take away one message from this today, if you don't look for the problems in the operating room, you won't see them. But you will when you get the call late at night. So most of the problems in the operating room are silent at the time. Now here's an example of where the usefulness of high-frequency ultrasound is pertinent. So we can all see a heavily calcified, diseased aorta externally. We can see it, we can feel it, we can palpate it with our finger. But much of what is going on in the aorta is endoluminal. And unless you look for it specifically, you simply won't see it. So if you manipulate that aorta in terms of cannulation, cross-clamping, or side biting, this is why you have a 2% risk of stroke in these patients. Now, if we use TTFM, sometimes it's dead easy. You see a graph like this. lima to the LAD, a flow of 5 mils per minute, pulsatility of index 6.3. Is there anyone in this room who would not revise that graft? So we all agree there's a problem with the graft. And when we image this graft, what we can see is that the toe of the anastomosis is blocked, but there's some retrograde systolic flow. And you revise this graft, and you've now got 40 mils per minute with a PI of 1.5. Here's another example of something that's very obvious. Edema to the intermediate to the intermediate coronary artery. Flow 1 mil per minute, PI 67.8. And when you look at this, initially the anastomosis seems patent on high-frequency ultrasound, but there was no effect to flow. And on further visual inspection of this graft, which I thought at the time, it was done by one of my trainees, but which I thought looked perfectly okay, there was clearly a problem with this graft. So we revised it. But the point again was, if we had not measured the flow in this graft, I would have assumed at the time, I thought it looked perfectly normal. So here, this is not a great graft image, but it's a flow in the lima to the LAD of 17 mils per minute. So it is about acceptable, but with a pulsatility index of 1. So let me ask the audience, who would revise this graft?
Look at it.
So everyone would accept this as normal. Who would feel uncomfortable with a flow of 17 mils per minute? Well, I did. Because I don't like to see a flow in an IMA to the LAD of 17 mils per minute. So when we imaged this with the ultrasound probe, we could see that there was an actual stenosis of the lima to the LAD graft. So when we revised it, we got a flow of 32 mils per minute and a PI of 0.5. But the point of this, if we hadn't made this routine assessment, we'd have sent this patient back to the intensive care unit with a stenotic IMA to the LAD. And the problem is, unless you make these active measurements, you just don't see it. So here's another case of mine. This was a localized, so this was a case where I had to do an IMA to the LAD that was diffusely diseased. So I had to try and figure out where do I put my graft of the IMA to the LAD, because it had multiple diseased areas. And eventually what I did was, in the bit in the circle, you can see what I decided to do was open the LAD at that point and do an endarterectomy, so that I felt I had a better area for doing the IMA graft. Now, prior to giving protamine, I thought we had acceptable flow with a low PI, low diastolic flow, and no backflow. So given this appearance, who would revise that graft? So I assume that means everyone in the room would accept that graft was okay. So nobody would say, I need to revise this graft. When we do ultrasound assessment of that anastomosis, what I see is there's a widely patent lima to LAD anastomosis, but there's a flap on the posterior wall. And the question to myself at the time, is this functionally important? Do I need to revise this graft? So let me ask again the audience, who would now revise the graft? Surely somebody must think we need to, yes. So Dr. Puskis, Dr. Shida, Dr. Freems, so 4 or 5 people say revise the graft. Can I raise that number? Can we get any more people to revise the graft?
Have to be there.
Come on. Pretend it's an auction. Okay, so I looked at this and my view was, this is not functionally important. Okay, I can see something on the posterior wall, but I didn't think this would be functionally important. So what I did was, I asked my anesthetist to give the protamine, and now look what happens. The flow drops to 11 mils per minute, the PI significantly increases, So who would now revise this graft? Good. Come on, more and more. Okay, so I looked at this and I thought, okay, here's the high-frequency ultrasound imaging now, and you can see again that the anastomosis is widely patent, but you still see this now disconcerting flap on the posterior wall. And the question is, do we revise? And now even I felt, got to revise this. So we revised it, and you can see on the right-hand side of this image, the flap that we removed from the posterior wall. And now when we look at the flow, it's gone up to 35 mils per minute. The PI has come back down to 1.5. And you can see with the ultrasound imaging that the anastomosis is widely patent and the flap has gone. Now, the reason I show you these images is very simply to make the point that if we had not looked for this routinely, we would have missed this. And this is going to be the final, just in the interest of time, the final image I show you. So this is a 48-year-old patient with a non-STEMI, occluded right coronary artery and circumflex, and with a significant LAD stenosis. Now, when I was referred this patient, I looked at the angiographic image, and I wasn't really convinced about this. I thought that LAD, I could see, in my opinion, a minor irregularity, but I didn't really think it looked like a significant stenosis. But when the FFR was done, it fell from 0.9 at rest to 0.7 on vasodilatation. So because the patient was 48 years old, the cardiologist requested Lima to LAD, and he wanted 3 arterial grafts. So the way I did it was Lima to LAD and a composite RIMA from the Lima to the OM and a radial artery to the PDA. Now, this patient was done on pump because the patient was in another trial which mandated the case had to be done on pump. And initially, it all looked reasonably okay. You can see from the jagged appearance of the trace that there's a bit of spasm in this arterial graft. But the limit to the LAD was 36 mils per minute on pump with a PI of 1.0. We came off pump, and we now had a flow in the Lima to the LAD of 4 mils per minute and a PI of 18.7. So what do you do now? Any suggestions from the audience what you do, apart from wish you hadn't used TTFM?
Yes, that's it.
Anyone? Suggestions? Please, Steve Freems.
I would put a clip on the radial artery PDA.
Put a clip on the radial artery to the PDA.
Wondering if there's competitive flow.
Yeah, okay. So that's one of the questions. Any other suggestions?
Temporarily,
Please?
I think the problem is that all the fluid is going in the RITA because of the competitive flow on the LAT, and there is severe stenosis on the vessels grafted by the RITA. So I suggest to do 2 inflows rather than 1 inflow for this kind of.
So what do? You phone your lawyer and you say to the lawyer, what should I do?
Yeah, I think the idea was to put the LITA on the aorta maybe in this case.
Put the lita to the aorta. Okay? Any other suggestions?
Imaging probe.
So who was that from, sorry? Imaging probe.
Check memory.
Absolutely.
Yeah.
So we check the mammary, and here's the flow, Lima to the LAD. As widely patent an anastomosis as you'll ever see. So I look at this, and there's one other thing I need to do in my algorithm. So I've checked the Lima to the LAD. What else do I need to do?
Why? To see if it's
Yeah.
No? So we've been caught out several times by this. The next thing you need to do is use your imaging probe to check your conduit. We have 3 cases like this where our anastomosis from the lima to the LAD is widely patent. But when we imaged the conduit, there was a dissection in the conduit. So initially, you look at the lima to the LAD. I don't have time to show, I've got a few more of these cases and time's going to run out. But the point of what I'm trying to say today is use an algorithm in your head. Check the flow. If it doesn't look right, it usually means it's not right. Don't ignore it and say, get me another probe. There's something wrong with this probe. The second thing to do is check your anastomosis. Because when you see a widely patent anastomosis like this, you're very, very comfortable, but you then have to say, why have I got a problem with flow? So the next thing to do is to use that probe to image your conduit. And I can show you three, I don't have time today, but I can show you three excellent examples of where there was no problem with the anastomosis, but there was a dissection in the ITA graft.
Been there.
So my take-home message from this is use an algorithm in your head. If the flow doesn't look right, it usually means it's not right. And do not assume it is competitive flow until you've imaged the conduit, you've imaged the anastomosis. Now, when you get a case like this, where we image both the anastomosis and the length of the graft, we did not revise this, but it's still very uncomfortable to have a patient going back to an intensive care unit with a flow of 4 mils per minute in the ITA graft. On that point, I'm going to conclude my talk. I'd like to thank the organizers again for the great privilege of being here today, and you, the audience, for your attention. Thank you.
So next speaker is Dr. Arai, epicardiac ultrasound, why, when, and how to use it. Please.
It's my great honor and pleasure to be invited for this presentation. So my talk is epicardiac US, why, when, and how to use it. Maybe Dr. Taggart explains so much about this kind. Okay, but anyway, I'll start it. So this is my disclosure. So before anastomosis, evaluation of the aorta. So my routine practice of epiaortic scanning is for the proximal ascending aorta, so how to put the proximal anastomosis, and then mid-ascending aorta, where to cross clamp or where to put side clamp. For the distal ascending aorta, where to cannulate. So for this is the most typical case. As you know, you can detect by plain CT, and also you can palpate this kind of calcification. But the echocardiography clearly shows the border of the normal aortic wall and the calcification. And this is the protruding soft plaque. Plain CT or manual palpation cannot detect this kind of soft plaque, but the aortic ultrasonography can find it. This is the second atheromatous intimal. Plain CT or manual palpation cannot show wall thickness. So in this kind of cases, you have to do definitely no-touch aortic techniques of CAP. And this is another diffusely second atheromatous intimal, very high risk of stroke induced by cross clamp or side clamp. This is a very interesting case. This is second intimal and mobile plaque in the origin of the innominate artery and the posterior wall soft plaque. Definitely the indication of the op-cap procedure without aortic manipulation. So epiaortic scanning for stroke prevention is the epiaortic ultrasonography enables visualization of palpable calcium plaque, non-palpable soft plaque, intramural lesions, and mobile plaque. Surgical procedures should be modified according to the individual atheromatous findings, site of cannulation, level of aortic cross clamp, avoidance of side clamp, conversion to op-cap. So according to the request trials, planned aortic manipulation was changed in 10% of the patient. So before anastomosis, evaluation of coronary artery in primary case, Okay, this is comparing to the cine angiograms. This portion is definitely into a myocardial lesion. This portion, you can see the septal perforator. This portion, you can see the calcium plaque. All this kind of precise information, probably you cannot get before the operation, but ECAS clearly shows. And this is an embedded coronary artery. You can avoid unnecessary dissection of the coronary artery. This is the intramyocardial LAD. You can avoid deep dissection and accidental right ventricular rupture, so select anastomosis site distally. So this is a case of the long calcified region. So for the proximal LAD intramyocardium, here calcium plaque, and for distally calcium plaque over there. So from these kind of multiple views, you can reconstruct the actual images of the coronary artery, and in this particular case, I have to make a long onlay patchplasty using liter. And this is another case. See, comparing to the actual vision of the operating view, there's the proximal LAD is deep into the myocardium. So I put the proximal snaring stitches a little bit deep. And this incision is over the calcium plaque. You can compare the actual calcium plaque and the visions. And the distally, relatively normal distal coronary wall. So in this case, I did a little bit long only patchplasty for this case. So surgical strategy changes in coronary target in 22% according to the request trials. You can even see the coronary stent. If there is some kind of special situations, you can see the border of the stent by using this color Doppler mappings. So that you can see precisely the shape of the stent here, and also that you lose its flow here, and you on the native coronary artery, you can see the flow over there. This is another interesting case of that. Sometimes the osteostenosis of right coronary artery is difficult to by the cine angiograms, kind of a pitfall of diagnosis. And if you put the probe at the origin, there I could find a mobile calcium plaque and the restricted right coronary artery flow. And in this particular case, I did aortic valve replacement and also the right coronary bypass. So actual picture is, you can find the actual plaque over there. So before anastomosis, in redo cases, evaluation of coronary artery. In redo cases, sometimes the patency of LADs, in this particular case, the patency of LAD is uncertain due to poor collateral from right coronary artery. But by scanning, you can find the actual position of the LAD. So location and patency of the target distal LAD was confirmed. And this is another case. So the distal right coronary artery cannot be observed by cine angiograms. So I precisely checked during the operation, and then I could find clearly where the distal right coronary artery is, and finally I anastomosed. This is another case of the redo valve surgery. Sometimes it was quite difficult to dissect to avoid the leader, and you have to clamp the leader for during the valve surgery. So, but by ECAS you can see this kind of shape, leader, but you are not sure is this leader or not. But that machine have a pulse wave mode. It can show that you put some kind of point over there, and then you can confirm the diastolic flow pulse wave pattern. And if you clamp it, suddenly this kind of diastolic flow pattern disappears. So definitely this is a leader. This is very useful. Okay, so before anastomosis, in case of emergency cases, so this is a case of acute aortic dissection. So the CT shows calcification in LAD and the right coronary artery, but you don't have enough time to do angiograms. During the operation, you directly scan the LAD and find the actually a calcium plaque over there. So we have to put the bypass to LAD, but for the right coronary artery, it was totally patent. So you don't have to put a bypass on this kind of cases. So after anastomosis, I always evaluate the coronary artery in case of long onlay patch to check the endarterectomy, especially after endarterectomy. So the heel of the graft and the toe of the graft. Okay, and yeah, if something wrong, we have to evaluate the coronary artery. So especially in marginal TTFM flow case, like Dr. Tagat showed, this is kind of marginal flow case of I made the right radial artery composite graft and 2 anastomoses to the posterior lateral branches. And the flow was 9 milliliter per minute, PI 3.0, diastolic fillings 74%. The PI and the diastolic flow is okay, but the flow 9 milliliter per minute is not acceptable. So, as Dr. Keith showed, I made a proximal oxygen test. So flow increased a little bit, 12 milliliter per minute. PI is okay, and diastolic filling 65%, but still suspectable. So do the images. So finally, I could find a good opening and systolic phase backflow of the right color and the diastolic blue flow going to the forward. So this is no problem. So I can leave the operating theater without doing nothing. So this is another case of it looks like acceptable graft appearance, but the flow was 10 milliliter per minute. Liter to LAT, 10 milliliter per minute is not acceptable. PI 2.1, they're okay. Diastolic filling 65% okay. So what should we do? Of course, we should make images. So in this case, in this particular case, it's an accidental dissection of the liter. So you can clearly show by the transverse scanning views like a similarity of the actual aortic dissection. This is very typical picture of and also the restricted flow in the true lumen. After revision, it can recover very nicely. And in-situ coronary changes happened in 3% of the cases according to request trials. So outside CABG, sometimes detection of the coronary fistula. So this is a very typical, interesting case of the giant coronary aneurysm and coronary artery fistula. I have to ligate the coronary fistula into the left ventricles. Of course, for this kind of typical cases, I take out the aneurysm and make a direct anastomosis, and also ligated the fistula. But at the actual view, where is the fistula into the right ventricles? I can't find it by eyeballing. So I put a probe over it, and then clearly I can see where the fistula is, and pinpoint, I dissected it and ligated it. And this is another interesting case, confirmation of the myectomy. This is a case of the HOCM. The peak PG was 69 and very thickened septal myocardium. So this probe we can bring into the left ventricle through aorta and can check the thickness of the myocardium. And step by step, I make a myectomy and then check it, and then, okay, I can make another extended myectomy and then I cut at it, and finally, I can get the satisfactory incision, myectomy, without perforating the left ventricular septum. And so, after surgery, the peak pressure gradient decreased to 8 millimeter mercury. I'm not expert of the HOCM, but I can do it safely. So how to use it? Some kind of case, special cases. Tips to obtain better images is stabilize the target vessels, obtain adequate contact with the target region, enough jelly, preferably with sonar pad. When longitudinal view is not satisfactory, take transverse view and reconstruct images in your brain, and sometimes be patient. So, and the sonar pad, but it is sometimes sleepy. So in that kind of case, I put a stabilizer, and also in combination of the integrated probe, I cut the finger of the globe, and inside the globe, I put the sonar pad and also gel over saline, and make a ligation and make a integrated probe. And this you can bring anywhere in the heart. So you can assess even a lateral wall, especially in this kind of situation. So prior to anastomosis, target coronary artery, whether intramyocardium, where is the calcification, or caliper is adequate or not, aortic wall, calcification or not, soft plaque, or worse, how about wall thickness? Anastomotic findings, is that okay? Or liter is okay. So nobody operates submarine without using ultrasonic sonar. Ultrasonic eye is an indispensable third eye for a surgeon. Let's do it. Thank you very much.
Thank you, Dr. Arai.
That was beautiful. Your images are gorgeous. I think we'll go on now to Dr. Mario Godino, perioperative ischemia, detection and management. On a different note. There you go.
Thank you, Teresa. And so this is what happens if you don't use the flow meter, right? Then you have postoperative ischemia. And I'm giving this talk on behalf of a number of authors, and we published recently this AHA expert consensus paper on the management of acute postoperative ischemia after cardiac surgery. So while it's me on the podium, I am speaking on behalf of all those colleagues. So the data on the incidence of myocardial infarction after cardiac surgery are mixed, with a pretty wide range from 0.3 to 9.8% after CABG, and higher than that after CABG and valve surgery. But we don't really have data on postoperative ischemia. I mean, it's very likely that the incidence of ischemia is higher than the incidence of MI, because we treat most of those cases because before an MI actually develop, but there is not really good data. The mechanism of postoperative ischemia are traditionally divided in graft-related and non-graft-related. Approximately 2/3 of the cases of postoperative ischemia happen after coronary artery bypass surgery, but probably 30 to 35% in fact are detected in patients who undergo other type of surgery. After CABG, clearly it's mostly related to the graft, either kinking, thrombosis, anastomotic issue. After non-cardiac surgery, the problem is most frequently incomplete revascularization, poor myocardial protection, ischemia reperfusion injury, or iatrogenic lesion to coronary artery during valve or aortic surgery. So those are the key diagnostic criteria that we all generally use after cardiac surgery to detect ischemia. None of them is perfect. clinical assessment as a major limitation in a patient in the early postoperative period. EKG changes are highly aspecific, and very recently, even the prognostic significance of EKG changes that we have traditionally considered as very specific, like ST elevation, have been challenged. I will discuss biomarkers in brief, and we have a great lecture after mine on biomarkers, but to cut the long story short, current definition of MI are using clearly inadequate biomarkers level. Echocardiography is sensitive but has not negligible risk of false positive, because there are a reason why you may have a wall motion abnormality that is not ischemic, and CMR and CT have been around for several years, but they are logistically challenged to be implemented in the early postoperative period. MI, our diagnosis of MI is based on a number of definitions, and yesterday John has covered the impact of that, the variability in those definitions had in clinical trials. However, from a clinical practice standpoint, what is relevant is that the threshold that those definitions used were probably solid when we were using CK-MB, but are largely inadequate now with the transition to troponin. So the troponin threshold used at the current definition range from 10 to 70, with or without the need for additional sign of ischemia. But the reality is that most cardiac surgery patients have postoperative troponin level that are higher than those definitions. The best example of it comes from the P.J. Devereaux cardiac vision study that was published recently on the New England Journal of Medicine, and you can see how the threshold of troponin that was associated with an increase in mortality was vastly higher, like several dozen of times higher than what is the threshold using current MI definition. Similar work has been published recently from Europe. This is a large retrospective study, and you see again how the threshold for postoperative troponin elevation that were associated with an increase in mortality is over 100 times the normal range. And in a relatively old post-hoc analysis of the coronary study, Andrea Lamy and this group found that the threshold that we are currently using to define MI based on troponin were met by over 90% of the patients who underwent bypass surgery. So clearly there is a need for revision of those thresholds. We have recently published an expert consensus document with ESCTS asking for a revision of those definitions, and hopefully it will happen at some time in the future. However, once you have made your diagnosis, no matter how you have done it, there are a number of clinical decisions that you need to make. You're going to the cath lab, are you bringing the patient to the cath lab or to the operating room, or are you opening the chest in the ICU? Do you need mechanical circulatory support? How do you want to treat ischemia, PCI, redo CABG, or just do nothing? So we tried to address all of that, and I think this is the really most important part of our document in this algorithm. It may seem complex, but it is in reality not that complex. I think the first assessment has to do with the hemodynamics. So if the patient, the first clear difference, if the patient is hemodynamic and stable or unstable, or there is a high suspicion of either mechanical complication or bleeding. In the latter instance, where you have ischemia, but you also think that the patient is bleeding or there is a mechanical complication, this is where probably the most rational approach is to reopen the patient in the ICU, not to lose any time and potentially to fix mechanical complication. If the patient is hemodynamically stable, then like David wrote in his editorial, the cath lab is definitely the place where you have to go. If the patient is not hemodynamically stable, well, then it depends if you have some sort of mechanical support available at the bedside or not. If you do have mechanical support, then stabilize the patient and bring him to the cath lab. And if you do not have mechanical support, then you are in a situation when, again, you better open the chest, try to stabilize the patient, and then potentially go either to the cath lab or the operating room. Once you are in the cath lab, then things are relatively simple. You can very easily make a diagnosis and make a decision of how to intervene. We don't need to go into the detail of how PCI must be done. We will go a little bit into the details of how CABG should be done. The majority of the cases can be treated effectively by PCI. It also allows a faster reperfusion, is probably safer. However, the CABG option is on the table, and in some patients, approximately 20%, you will not find a clear reason for the ischemia, and so in those cases, medical management is your only option. Now, if you have to go to the OR, the expert group are some general consideration, which I think are common sense consideration. Don't be too fancy, just do what you know how to do. The goal here is to reperfuse as quickly and as effectively as possible. So if you're an on-pump surgeon, do it on-pump. If you're an off-pump surgeon or off-pump, don't be too concerned of arterial conduits and long-term patency in that situation. The saphenous vein graft is your best friend. It's quick and effective, is always available, so that is our suggestion. Technically, what I've found, and my colleague on the working group agreed, it's easier to perform a new graft distal to the anastomosis that is in trouble rather than taking down that anastomosis and performing a new one. Clearly, if you have that option, because your first anastomosis was already very distal, then you can only take it down. So my conclusion after this short talk, perioperative ischemia is an uncommon but important complication of cardiac surgery. Key treatment decision must be made at the moment of the diagnosis or at the moment that there is a suspect of the diagnosis, and time really does matter. So the quicker you start thinking about it and the quicker you make your decision, the more likely you will be successful. As always, you need the expert colleague. I would say interventional cardiologist and critical care help is really critical in this situation. In general, the quicker you can get to do the cath lab, the better your outcome will be. And having said that, I thank you for your attention.
Very good, very good.
Okay, the last speaker is Dr. Tommy.
Sorry,
Yeah.
Hiroshi, could I ask one quick
yes.
question, please? Mario, very nice talk, thank you. Just one question I have for you. I agree in general terms that if you can back to the operating room and you think there's a problem with the graft, that you go distally. The problem is if you've grafted the mid-vessel and you've got a problem with the heel of that graft, grafting it distally can leave a big septal area unperfused. So I'm not 100% convinced that I mean, I get what you're saying, obviously, but I'm just thinking that in practical terms, if it's a big mid-LAD lesion, then my view would be to take that anastomosis down and redo it, because I'd be worried about leaving no retrograde perfusion.
No, that's a great point. You know, we had limited wording space, so I think that was the most effective way to communicate. But you are right, understanding, David, that the flow chart highlight the importance of going back to the cath lab as quickly and as often as you can. So you will have guidance, and in a situation like that, where you know the problem is the proximal part of the anastomosis, it wouldn't make sense to go distal to that. You are right. But in case you know that the problem is not necessarily a proximal occlusion, I think it's just easier to go distal and do a new fresh anastomosis rather than taking it.
Just quick.
Just going to ask a quick follow-up question, Hamza Aziz from Hopkins. Timing-wise, let's say if it's a day after or 2 days after the graft goes down versus 6 hours, the night of, decision-making whether to go back, and that question of revising graft versus a new graft.
So
meaning like, let's say 2 days have gone by and the patient crashes on the floor, not in the ICU.
Yeah.
The graft is, you take him to the cath lab, graft is down. But there's like some time has gone by now, as opposed to 2 hours or 3 hours after ICU.
I don't think timing per se is an issue. I think if even 3 days after, and it may happen, your graft you go down, you go to the cath lab. My preference in general, and the other group agree with that, was to try to not to go back to the OR and fix the issue on the PCI table. That is generally the straightforward approach, and it's also easier, faster in terms of reperfusion. But if you have to go back to the OR, 2-3 days, you will not find dense adhesion yet. So I mean, you just go back into the same that you would do 2 hours later.
Thank you very much. So the last speaker is Dr. Tommy, please.
Thank you. To the organizers of the conference and the moderators, I'm very grateful for the opportunity to be here today. I should disclose that I'm not a cardiac surgeon, but rather a client of yours. Very grateful for the opportunity to refer cases of mine to yours, and certainly to the wonderful team we have here in New York at Mount Sinai. I have no pertinent conflicts to disclose. As an aside, I'm looking for some if anybody knows of any tips. I'm, in my capacity as a cardiologist, rather intimately and tumultuously related to cardiac troponin, the topic of my talk today. But I was a little bit curious in the practice of this world group. Is it routine for you after your coronary artery bypass surgeries to obtain serial troponin measures, just by a show of hands? Many, but not universally. We're, of course, routinely in this practice after percutaneous interventions, but I was interested to learn a little bit about the practices. So I need not get into the details, but certainly the troponins are important proteins involved in the thin filament aspect of muscular sliding filament theory and contraction of muscles. There are troponins I, T, and C that have isoforms that are particular to cardiac or skeletal muscle. And our ability to have assays for cardiac-specific isoforms permits this to be a quite specific biomarker of myocyte injury. Suffice it to say, there are a variety of mechanisms above and beyond necrosis alone by which cardiac-specific troponin can be released. We think about necrosis in the context of myocardial infarction, but certainly apoptotic pathways, myocyte turnover, blebbing, membrane permeability, as well as proteolytic degradation can all be contributors to the troponinemia that is observed after varied cardiac procedures. At the bottom, as is outlined here, within the specific confines of coronary artery bypass grafting, there are a number of elements of the procedure, the manipulation, and its aftermath that could bring about release of troponin that is detectable were you to measure it. Taking a look at how troponin tends to be released, there is a stereotypical kinetic pattern to how troponin releases in the hours following surgeries. And generally speaking, within the first 6 to 8 hours or so, you're going to see the peak of a troponin elevation that's attributable to surgery. Of interest, if you look comparatively at on versus off pump procedures, the magnitude of that spike is markedly different, really by a difference of more than twofold. I think it's pertinent to be specific about which cardiac isoform of troponin we're referring to. And notably, if you're looking just at troponin T, you might see substantially lower spikes than you would anticipate with troponin I, which can lead to a more than twofold difference in the peak magnitude of troponin that you would see after cardiac surgery. To the extent that each of our institutions may specifically have in its laboratory one or the other of these assays, it's important when thinking about definitions of cut points for myocardial infarction to be very precise in which measure is being used. There are varied definitions, and I'm very grateful / anxious to be on the heels of the prior talk, which have covered some of my content, so I'll be concise in the interest of saving time for discussion by the panel. But suffice it to say, there are different definitions for myocardial infarction in the aftermath of bypass surgery. And I won't get into the details, but the fourth universal definition relies upon one particular definition of cut points for biomarkers, and in particular for definition of myocardial infarction. Considerations include whether or not there was troponinemia preceding the bypass surgery. And of note, we don't always have the luxury of troponin measures in the immediate lead-in to surgery. This becomes particularly concerning if you think about the high sensitivity measures, which are not infrequently chronically elevated as a sort of chronic myocardial injury in patients with substantial multivessel coronary artery disease. So in interpreting whatever troponin elevations are observed postoperatively, we're somewhat flying blind without knowledge of the preoperative troponin levels. And it is important to have this delta of at least 20% to at least satisfy these criteria. Importantly, depending upon the magnitude, there's an importance to having corroborating evidence, which might come from development of new electrocardiographic changes, angiographic documentation of either native or coronary graft failure, or imaging evidence that's indicative of a loss of viable myocardium, which most often is going to be available to us via echocardiography. Now, within the confines of the UDMI, there is this concept of what do we do with the isolated elevation of biomarkers in the absence of these other pieces of evidence. And while it doesn't necessarily satisfy definitions of myocardial infarction, it constitutes a cause for some concern and perhaps a motivator to investigate whether anything might have gone wrong that occurred silently within an operation or otherwise portends risk to the patient. Now, as was previously noted, there is discordance if you look at varied definitions of periprocedural myocardial infarction. These are three in particular here, the universal definition of MI, the fourth version in particular, the SCAI definitions, and the academic research consortium definitions, which vary quite dramatically. If you look at what the measures are being used, whether or not CKMB is a preferred agent or rather troponin itself, what the cut points are as a multiple of the upper limit of normal, and what the demands are for other elements of corroborating information. And within this discordance clearly arise several dilemmas, which I think will be most fruitful for the panel to discuss. Namely, first and foremost, should we be in the routine practice of measuring troponin in the absence of any motivating clinical concern? Is this something that ought to be an element of our screening for adverse events? Secondly, if we are going to be doing this routinely, what is the clinically pertinent threshold to prompt clinical concern and further investigations? And third, what are the implications of the thresholds that are ultimately chosen for how we aim to interpret trials that are measuring the safety of given interventions, coronary surgery, percutaneous coronary entrant, or otherwise? And then finally, to what extent do these new high-sensitivity assays complicate interpretation? So, a few words about some comparative utility of different definitions for interpretation of clinical outcomes. So if you were to compare the predictive utility of the thresholds provided from varied definitions, they differ importantly. So the SCAI definition really provided no independent prediction of major adverse cardiac events at the 5-year mark. Whereas if you use the fourth universal definition of MI, there was evidence for an independent predictive role. Similarly, with the Academic Research Consortium myocardial infarction definitions, when they're incorporating the corroborating evidence from other modalities. Notably, in the ARC, if you didn't have this corroborating evidence, the biomarker threshold by itself was not sufficient to be independently predictive. Of interest in this particular analysis, there was predictive utility to ECG alone. And there are fairly similar comparative performance of the metrics when looking at 5-year mortality in isolation. Now, how about high sensitivity troponin? Again, as was shown, if you look at how much high sensitivity troponin elevation you need as a percentage, or as a multiple of the upper limits of normal, it's markedly higher than what currently exists in present definitions of myocardial infarction. In this particular study from Canada, you had to have a 218-fold increase in high sensitivity troponin in order to satisfy a predictive role. So in conclusion, there are really multiple mechanisms that can account for measurable troponin release after bypass surgery. And the contemporary assays that we have, particularly the very high sensitivity troponin, are highly sensitive. And we need to be very humble about how to interpret these biomarker abnormalities. How we choose to interpret the clinical relevance of troponin is going to be enhanced by any corroborating data, and in particular, ECG seems to provide some utility, although as was noted before, we need to be careful with looking at EKG in isolation, given confounders for putatively ischemic events. And then finally, the thresholds for relevance of troponin as an isolated biomarker need to be higher, especially with emerging data. And this is critical as we think about how to interpret emerging clinical trials. So thank you very much for having me today.
Could I make a quick comment, please?
Please, David, yes.
Thank you for your very nice presentation, very clean and smooth. I think the difficulty with people interpreting what's happening, and you alluded to it, because my own group published more than a decade ago the difference in troponin release between bypass and off-pump surgery. And what was not clearly understood was that about 8% of troponin is actually in the cytoplasm and not bound to muscle. So if you put a patient on bypass, you get this permeability leak. So you see this very sharp rise within 12 hours, but you know that this is not irreversible myocardial injury, because if it was, it would not come down sharply within 12 hours. So that's a permeability leak. It is not myocardial injury. And that's why you see that difference between on-pump and off-pump. And where people are making a mistake here is that they should be measuring the troponins at 24 to 48 hours. Because if your troponin's up then you've got myocardial injury. But this measuring troponins early is not true myocardial injury, especially when you've been on pump. It's a permeability leak from cytoplasm. But thank you for your very nice presentation.
That's good to know. Thank you, David. That's good. I think maybe you want to contact people after the talk, because I think we're behind. Are we? Yeah, we're going over time. So if you want to have any burning questions, John, are we? Okay, good. Okay, we'll wrap this up. Thank you very much for a great session.